I think without delay, let us start straight off with the topic. Today, we are honored to have Dr. Alfargal himself, who has come online from his place of work. Where are you now, right now? Are you in Egypt or in Saudi?
Saudi Arabia, Jeddah, King Abdulaziz Medical City, and King Abdullah um, Specialized Hospital for Children.
And I see that it is a daytime there because there's a light from the window.
Yeah,
Yeah.
we are expecting Ramadan tomorrow, so
So I
we're
caught you
just
before that.
being prepared
I caught you before
to
that.
adapt our daily activities for Ramadan, the
So,
fasting
so
time for
we
Muslims.
can start telling you Ramadan Kareem from now on.
Yeah, you can do that. Thank you, Dr. Ravi.
Thank you.
Thank you very much, my friend.
So today's topic is something which is close to all of us. That is, how do you use a VNG machine to help diagnose and manage BPPV? And so, without further ado, I request Anusha to start the presentation.
Yes, sir. Thank you, sir. Hello, everyone. Today's topic is importance of VNG in management of BPPV. So before going into the actual case discussions, I want to discuss briefly about BPPV. As we all know, benign paroxysmal positional vertigo results from dislodgement of otolithic crystals from the utricle, which enters any semicircular canal, making it sensitive to gravity-related movement in the corresponding plane. So, but why BPPV is the more important for any vestibular specialist is, first is it is the most common condition, and second, it is the treatable on the spot with appropriate repositioning technique. So we as vertigo specialists should not miss any diagnosis of BPPV and should be able to reposition the otoliths completely. So the diagnosis of BPPV mainly depends on eliciting positional nystagmus by various positioning tests. So general characteristics of the BPPV related positional nystagmus are listed here. So this positional nystagmus, which is elicited on positioning test, should be associated with the symptomatic dizziness or vertigo. And there should be some latency. That means nystagmus should start after a few seconds after positioning the head in the provoking position. Sometimes that latency will be very less in cupulolithiasis conditions. And coming to duration, it will be short duration of about less than 1 minute. And also it follows the crescendo decrescendo pattern. That means the intensity will raise and then decreases slowly over a time of 1 minute. And there will be fatigability to the nystagmus. The intensity of nystagmus will decrease on repeating testing. So these are the general characteristics of the BPPV related positional nystagmus. So each semicircular canal involved will produce the characteristic positional nystagmus of its own, which will depends on mainly its vestibulo-ocular reflex connections. So if we see the if the involved canal is posterior semicircular canal, generally we'll test it with the Dick-Salpike test, and it will show the upbeating nystagmus with torsional component towards the same side. And if the involved canal is horizontal semicircular canal, we'll test it with the supine roll test or Macular-Pagnini test, in which if the nystagmus is horizontal nystagmus, but like on right lateral, if it right beating, and left lateral left beating, means it is geotropic horizontal nystagmus, which will indicate that canalolithiasis of horizontal semicircular canal. If it is opposite, that means on right lateral position, it is left beating, and on left lateral position, if it is right beating, that is apogeotropic horizontal nystagmus. It is seen in cupulolithiasis of the horizontal semicircular canal. So coming to anterior semicircular canal, it is tested with the supine straight head extension test, in which we can see the down beating nystagmus predominantly, and with or without minimal torsional component towards the same side. So this is just to brief introduction of BPPV. We all know that. And coming to what is VNG, actually, video nystagmography test is a video-based computerized non-invasive test, which is having this equipment One is goggles with infrared light source and inbuilt cameras. This infrared light source is useful in recording the catch up the eye movements in dark situation also. When we cover the eyes with the flap, there will be darkness. So in the darkness also we want to see the eye movements. For that, this infrared light source will help. And it will be connected to the computer. So it will show the real-time video of the eye movements as well as the graphical representation, which can be stored. So this VNG has a better resolution of about 0.1 degree of eye movement, and it can measure the nystagmus of intensity as low as 0.5 degrees per second. So how this VNG can help really clinicians in the management of BPPV? So generally it is true that we can do all the positional tests clinically without any equipment, and we can diagnose the BPPV of involved canal, and we can reposition clinically also. But how this VNG helps means, one obvious thing is for documentation purpose, and second one we already discussed about it. That means fixation means opening of the eyes. If it is fixated on one point, this can suppress to a partial extent this positional nystagmus which is elicited. So to remove that fixation effect, we'll use the flap, and in the darkness also, to record the eye movements, we can use this VNG goggles and VNG setup. So second one is that. And still how it helps is, I want to discuss some few case scenarios. So yeah, which actually VNG helped me in critical way in these cases to manage the BPPV. So first case scenario is, we got a 32 years old female.
So, Anusha, just a request.
Yes.
After finishing each case, just let us get Dr. Alfargal to give his opinion and discuss it. Otherwise, you'll end up speaking the whole time. It will prevent us from gathering his experience into the discussion. So, after finishing the first, I'd be happy if you would invite opinions.
Yes, sir. Sure, sir.
Please. Thank you.
So yeah, we'll discuss about first case scenario. We got 32 years old female who is an housewife. She is mainly complaining of multiple episodes of spinning sensation on lying back and getting up, especially on the right side, which is associated with head heaviness. So it is typical of positional vertigo only. So she has consulted many doctors for the same problem and got diagnosed to have right posterior canal BPPV, and they have tried Epley's manure twice before, but there is no much improvement. Yeah, that is the history of the case. Then I wanted to, but the history is typical of positional vertigo, and she is saying lying on right side, I'm getting more of this spinning sensation. So I was very sure that this is a BPPV case. So I went to positional test under VNG. So if I see that positional test, Dixalpec test, if I see, there is no finding, like no much nystagmus here. We can see on the right side, there's a very few horizontal beats are there. On left side, a few upbeats are there. But symptomatically, she is feeling very much giddiness she is feeling. She is even not allowing us to do Dixalpec as well. But to see the finding, there is no much finding in the positioning test. So we have completed all the VNG battery. In that, the positive findings I got is, there is saccadic smooth pursuit, and there is deviated subjective visual vertical on background. So here we can see with blank background, there is she can able to do that subjective visual vertical very aptly, but on background it is very much deviated. So more than 3 degrees is considered as like negative subjective visual vertical. So And going to, I have probed the history little bit like deeper. So she told that she had some migraine headaches in the adolescent age. So now she had only head heaviness and also these giddiness spells, which is having more of positional vertigo. So on these findings and along with the history, depending on this above findings, patient was diagnosed to have vestibular migraine, and she was treated with anti-migraine medications, and eventually she was relieved from the symptoms. This is the first case.
So
So
let's just have a brief discussion on this before we go forward. Dr. Alfargal, you saw her.
Thank you, my dear friend, and thank you, Anusha, for the nice presentation. So we'll start from the end. So migraine and the BBV, there is a close relation between migraine and the BBV. So in the literature, that people with migraine, they have three times, three folds more than general public to develop benign paroxysmal positional vertigo. That's why there is, and from my clinical experience, yes, there is a relation between the vestibular migraine and the PPV. And we classify the PPV into primary when there is no autological neurological disease or trauma, and the secondary when there is like autological disease or also there is migraine. So sometimes the BBV is secondary to the migraine, to the vertebrobasilar insufficiency. And that's always causes recurrent. If you have active pathology in the behind the scenes, that's why it could trigger BBV more frequently than usual. And the trauma, which is a category, it's called post-traumatic BBV. So that's first point. Second point I want to highlight, it's also important when you assess the BBV is always also to see the videos of the nystagmus, because sometimes you have to see the videos, you have to see the traces from the video nystagmography. So it's also important to watch the videos and to compare between the traces and compare to the symptoms. Whenever you have a strong history suggestive of BBV, like the history in this case, and when you do the Dixwell-Bike test, you have negative test. Still, you shouldn't rush to exclude the presence of benign paroxysmal positional vertigo. First tip, you can ask the patient to come in the early morning at the beginning of the clinic to examine, because it's well known that is the otoconia and the crystals will precipitate at night, and it will become very symptomatic in the early morning when awaking from sleep in the morning. So that's why one of the tricks we use when we have that subjective BBV without any nystagmus, we ask them to come in the morning. And if you ask most of your patients, always the worst vertigo comes when they awake from the bed. And this is logic because in daily activities, the otoconia spread all over the canal. But when you lie down, it just precipitate. That's why also BBV is more common on the sleeping side. So one another tip also, you can do something called loaded Dixwell bike test. Loaded Dixwell bike test. So you can Google it. That's very nice technique. We adapted since published in our clinic. So we let the patient to stay in the head pitch forward position for like half a minute or 1 minute. So this is, we'll do some mechanical changes and make the nystagmus more robust. So before excluding the BBV and before being intimidated by the presence of vestibular migraine, sometimes really you have to get sure really that PBV is not there. So this is another point which I wanted to talk about. Um, Also, when you started your introduction about the BBV, you put the classical, which is written in the box. And the scenario you mentioned, it's not strange. In the literature, or also it was reported that even in the United States, with the best healthcare system, still a patient with BPV sometimes need more than 10 consultations to be appropriately diagnosed and treated. And that's why we are very, very keen to spread the knowledge and to educate and to involve more people in the field. So it not be restricted only for otolaryngologist or audiologist or physical therapist, but we need family medicine people also to be involved because the physicians or clinicians or healthcare professionals, they don't diagnose anything they don't know about. That's why we talk a lot, we do a lot of public awareness activities to pay their attention to the vestibular disorders. And yes, BPV is the most common vestibular disorders. When you put the criteria um, for diagnosis, just a few points. It's also typical as textbooks, but also now there is more changes in the knowledge. We better now understand the BBV to some extent, still not fully, but we are in a better situation. So yes, the diagnosis of BBV is always linked to the nystagmus, not to the position, because the very solid, the very solid, the very solid physiological fact is that is each semicircular canal is connected to a pair of extraocular muscles, which get activated in excitation, and another pair of extraocular muscles, which get activated during the inhibition. And by understanding the Ewald's law, which is the alphabetical of vestibular practice worldwide, and I highly encourage everyone to go through the Ewald's law because this is the alphabetical of vestibular practice. You can understand where is the otoconia is located, how it's moving ambulopitally or it's moving ambulofugally, it's moving towards the ampulla or towards the utricle. Even this is very important during the repositioning because you can do repositioning under monitoring using your video nystagmography system. So you can understand it's always for me easy. I have a big team, and during the testing and the diagnosis, I tell them this is going to work because we do it under monitor. So from analysis of the eye movement and the nystagmus with each step, we can know if the otoconia is going out, clearing out from the canal or no. So this connection between, it's very solid. This is the solid physiological part, the connection of specific extraocular muscles to the semicircular canal. And each one is connected to a pair during excitation and to another pair during inhibition. So analysis of the nystagmus is always a key factor for the success in diagnosis and the management of the benign paroxysmal positional vertigo. Now, actually, the literature says that is, and also our experience, that the otoconia is not like before canalicysis, cobulocysis. No, I think we have, the literature says 5 possibilities of where is the otoconia placed in the semicircular canal. And I personally, from our experience, I add a sixth position, like the common crust, when the otoconia is the common crust. So the otoconia can be in the ambulary arm of the canal, non-ambulary part of the canal. It can be in the copula. It can be on the copula from the canal side. It can be on the copula from the utricular side. So just having such, yes, basics is very important, and the common is common, but we have to be open for other possibilities. And we work to develop our skills and knowledge how to interpret the nystagmus of the benign paroxysmal positional vertigo. In the diagnostic criteria, our dear colleague put in the introduction that it's fatigable and it fade out with repeating the testing. Actually, I would recommend to remove this one and to add it is cleared by repositioning maneuver or not, because actually this is This is very, very specific. If the nystagmus cleared by repositioning, so that's a good indicator. It's most likely BPV. So instead of just, as mentioned in the text box, that is, it's fatigable or something like this, it's better just we change it if it's cleared by repositioning maneuver or no. In my humble personal opinion, this could be more of diagnostic value. And sometimes in doubtful cases, we just try the repositioning and see the result. Also, it was reported in the literature something called subjective BVV. So when you have very small otoconia, which cannot elicit nystagmus, but it can elicit the feeling of vertigo or the symptoms. So sometimes also it get cleared with repositioning trial. I think these few points I would really recommend to keep in your mind. One of the advantages also for using video nystagmography system, it helps you sometimes to determine the direction of nystagmus, and especially in the Cyclops system, which I do use personally. So it can give you analysis about angular analysis of the direction of nystagmus, so you can know if it's there is upbeating component or the horizontal component or downbeating, because sometimes in a strong or weak nystagmus, sometimes you cannot exactly know the direction of the nystagmus, and also the duration. So it's good to have something which can calculate the duration of nystagmus for you. Because even in determining which side is more affected in horizontal canal or something, so some clinicians, they use the duration of the nystagmus as also one of the indicators. So those are the points I wanted to share with you.
There was a question which
Okay.
came on the chat asking if you don't see a torsional component, how important or unimportant is that? Would you care to answer that, Dr. Anand?
Yeah, sure. That's very interesting question because um, pure upbeating, nystagmus and positional testing, that's very common finding in migraine. Also, it's a common finding in smokers. It's common finding in smokers and it's more common in migrainer. So it could happen. And it could happen due to benign paroxysmal positional vertigo. In one very specific case, which is the bilateral posterior canal, benign paroxysmal positional vertigo. So when you put the patient, it's one of the tricks or the ways how to differentiate. Is it unilateral, pseudo bilateral, or true bilateral benign paroxysmal positional vertigo? So suppose if you have one patient with true bilateral posterior canal benign paroxysmal positional vertigo, and you put him in the you put the patient in the head extension, straight head extension position, what you expect? So the torsional component from the right side will cancel the torsional component from the left side, and that's why you have pure upbeating nystagmus. But generally, yes, if in Dixwell bike test, the absence of the torsional component lets you, it would be less likely to be benign paroxysmal positional vertigo. I hope I answered the
Yes, you
question.
did. You did.
Yes, we must
Anushakti,
see
you
the
can
video
continue.
as well to look the torsional component. We must see the video as well along with graphs to look the torsional component. So yeah, in this case, there is no torsional component as well. Can we go to
For
next
Yeah,
scenario?
please go to the next one.
Yes.
It would be nice if you could present the video if you had. Yeah, go on.
Yeah. So yeah, next case is about a 29 years old female who is a student. She came with a short spinning sensations on rolling to left and right and left on bed. This is she is observing since 10 days. So typically history indicates like horizontal canal involvement. So Yeah, coming to positional test here, in McClure-Pagnini test, we found nystagmus. I'll show you. Yeah, in right lateral, we can see the right beating nystagmus. Left lateral position, we can see the left beating nystagmus. And while doing the test, actually, the patient is feeling both sides equally symptomatic, and she is not able to like tell which is more intense. And we also, while observing the nystagmus, both sides, it is almost equal. So if we see the to find out the what is the side of the involvement of horizontal canal, generally this nystagmus is right beating on right lateral and left beating on left lateral. It is canalolithiasis of horizontal semicircular canal. The side of involvement will be determined by the more intense side, more intense nystagmus, which is on that side, it is considered as the side of involvement of the horizontal canal. So here, while looking at the nystagmus with naked eye, we couldn't able to find out which is more intense, which side is more intense. So if we see the clearly the values here, this is the right beating on right lateral. We can see here the horizontal component slow phase velocity is in around 20s, and here left lateral, if we see the horizontal component slow phase velocity is 13, 14 like that. So it is more intense on right lateral position. So we have diagnosed it as right horizontal canal canalolithiasis, and we tried Guffoni manure, and it was successful. She was non-symptomatic and no nystagmus after the manure. So this is one of the help we can take from VNG in determining the side of the involvement in case of horizontal canals. Yes,
So,
sir.
again, comments open for Dr. Alfargal. What would you say? What would you comment on this?
Yeah, that's a straightforward case. Yeah, if the history is, but just wanted to say when you have horizontal canal BBV, actually, any head movement is symptomatic. That's why the Italian colleagues they published about the um, head pitch forward and head pitch backward, the bow and the lean test, because actually in daily life, those patients not only get symptomatic turning from right to left, but also in bending the head forward or backward, because actually the plane of the horizontal canal it can be really allow its alignment to the gravity. It can allow the autoconia to move in these positions. And it tell you something very little bit strange, but I observe it. Most of them they complain more than they have more symptoms when they just bend their head forward. So that is the first point. So we have to understand that especially the horizontal canal, any head movement, it can trigger the symptoms, not only right and left. And that's why this is the reasons why upright examination for the horizontal canal have been published and widely popular, bow and lean test, because actually it work and it triggers the nystagmus. So that is the first point. Second is in geotropic variant. The strong side will be the symptomatic side. And this is simply because one, in the literature, there is always three equals law. But it seems there is another law which is not always highlighted. That is the semicircular canals, they respond more to excitatory stimuli than inhibitory stimuli. So this is one of the laws or the rules how to interpret and how to understand the vestibular system. So always when the otoconia move in excitatory direction in that canal, it will evoke more stronger nystagmus. When it move into an direction which causes inhibition, That it will become less strength and less duration nystagmus. So in the lateral canal, according to the Ewald's law, ambulopetal endolymphatic flow is excitatory and stimulant. So in the horizontal canal, if it's from the right side, geotropic variant, when the patient moves the head towards the light, there will be stimulation to that ampulla. That's why it generates stronger nystagmus. When he moves to the other side, that it will be moving away from the ampulla, which is inhibitory for the lateral canal, and that's why it gives a weaker nystagmus. So again, Ewald's law are the alphabetical. And to summarize for you, first law, each semicircular canal will generate nystagmus eye movement in the plane of that canal. Second law, that is for the horizontal canal, ambulopetal endolymphatic flow is excitatory, ambulofugal is inhibitory. For the vertical canal, the posterior and anterior, ambulopetal flow is inhibitory, ambulofugal towards the utricle is excitatory. And you can add that law which I just mentioned. All the semicircular canals respond to excitatory stimuli much stronger and more than the inhibitory stimuli. Thank you.
So the follow-up question which I have is, how often do you have to look at the VNG as against only the eye movements?
No, it's always I like to look simultaneously. It's a habit because sometimes you get views also. Yes, she gets a very clear difference in the slow velocity readings, and you can also get cues about the duration, how the nystagmus is persistent. And if you don't know, when they started the caloric test, they didn't use slow phase velocity. At the beginning, they used the duration of the induced nystagmus as indicator of the responsiveness of the labyrinth. So the direction, slow phase velocity, and duration of nystagmus, you can get that data. Crescendo, decrescendo pattern also, sometimes you see it more clear. So it's a habit. I look both. And fortunately, most of the VNG systems, including the Cyclops system, as examiner, you can see both. You can see the videos. If you look to the laptop, you can see the video, and you can also look at the tracing at the same time.
Anusha, you have one more case you can.
Yes, sir. Yes, sir. In this, I want to add, sir, like generally in McClure-Pagnini, we'll do first sit to supine test as well, which will aid in the determining the side. But unfortunately, in this case, sit to supine, we didn't have any nystagmus. Only on right lateral and left lateral we got. So that's why we have to depend it on the values of SPV only. And that point I wanted to add, sir. So we'll move to next case scenario.
Okay.
Shall we, sir?
Yeah, please.
Okay, sir. So here we got 37 years old female who is a housewife, and she is complaining spinning sensation on lying back and getting up, which is since 15 days. So this is also typically positional vertigo she is telling, and she consulted for the same twice before, and she got diagnosed to have BPPV and got Epley's maneuver also done twice, but there is no improvement after that. So she came to us, and then the positive finding is same, like positional test on Dixalpec test on left. It is typically, sorry for the, like I didn't have video now. So yeah, we got upbeating and torsional component towards the left side. On left side Dixalpec test, here typically it is there. Vertical component, it is more prominent, and torsional component is also there, but yeah, I don't have video right now. Sorry for that. So we have diagnosed this case as left side posterior canal BPPV. So we tried to reposition. So repositioning maneuver generally we'll do with Epley's maneuver, or sometimes Simmons also we can use. In Epley's maneuver, if we see, these are the steps from here A to this again to the sitting position. So here if we see this Epley's manure, throughout that manure, we are moving the particles from like this end to the into the utricle. Again, we have to push the particles from the canal into the utricle in this way. So while doing this, each step, we are moving step by step slowly from here to here and here to here, here to here, and then lastly to the utricle. So if we see this movement throughout this test, we'll get that endolymph movement in only one direction. That means it is moving ampulofugal way. That will cause excitatory nystagmus for the posterior canal. That is nothing but upbeating and torsional towards the same side. So throughout the throughout the repositioning manure, throughout the Epilis manure, we should get upbeating and torsional towards the left side only from this step to last step. So that is the important point. So while doing the manure, we should get the nystagmus only one direction. That means upbeating and left torsional. In each step, we should get that. So, but what happened in my patient is, see, here we have started with the sitting left side head turn, 45 degrees. Here, obviously, there is no nystagmus because there is no much movement of otoconia. And then next step is head extension with the left side turn. Here, this got triggered. This is expected. That means hub beating with left torsional nystagmus we can see here. And then next step, there is no much nystagmus, but very, very mild few upbeats are there. And coming to next, rolling over to the other side, right side, there is reversal of nystagmus. That means upbeats are converted into downbeats here. So what is happening is here, so up to here it got moved. That means 2 steps it got moved. After that, it is again re-entering into the same canal. That's why we are getting opposite nystagmus. That means downbeating, opposite nystagmus. So it indicates block here, block in the long arm of the posterior canal itself. Most commonly, it is seen in a large size of the otoconia. So for this, we have tried repeated dixalpike on left side to remove the block. That means to and fro movement of the endolymph we have elicited. And then we have repositioned it with Simon's manure, which uses the more inertial force that can help in removal of blocks. That's why it is called as Simon's liberatory manure. So here we can see that manure steps. So first opposite side head, sitting with opposite sides head turn. And next step is touching the parietal eminence on the left side to the cot on the left side, lying on the left side. So from this position to next position, that means touching the frontal eminence of this side to opposite side. From this position to second position to third position, we should move very fastly within 1 second. So it uses large inertial force. It can remove minor blocks as well. So this after this manure, we got successfully repositioned. There is no nystagmus afterwards. So patient was relieved by her symptoms. So this is last case scenario I wanted to present today.
So
Okay.
brings us
Thank
to
you,
the question.
dear colleague. Just I have to correct here. It's published and well known in the literature, that is, if you have the same nystagmus in the Dixon-Back test in the second position of Ebley maneuver, which is means just turning the head 90 degree to the healthy side. If you have the same nystagmus, that means it's a good indicator. But in the position number 3 and the 4th, it was reported that you can expect to have downbeating nystagmus. So you can expect, because you forget that posterior canal is connected with the anterior canal through the common cross, and that their entry to the utricle is together through the through the common cross. That's why at a point also the anterior canal can be stimulated. If the like endolymphatic flow is going toward the utricle, that means ambulophugeal, that it can excite the anterior canal. That's why you can get the down beating nystagmus. But your interpretation was against this is well known, and it was there is some reports, and you can Google for Asperilla libonati something about the good indicators during benign paroxysmal vertigo. So it's only in the second position you should get the same upbeating torsional nystagmus. But if you get it in the third or fourth, keep on your maneuver, then recheck, because most likely it can happen. And even some clinicians, they consider it's a good prognosis. So I disagree with your interpretation. I regret for this. One more thing, the canal jam is presented not by reversal of the nystagmus during the Ibli maneuver, but it's presented by persistent nystagmus. Persistent, even like spontaneous, persistent nystagmus, because it create a plug and like a vacuum, so it keep on continuous stimulation or inhibition of the ampulla. So this is how the canal jam presents continuous nystagmus, not just to reverse the reverse its direction. So I guess if you just completed the Ibli, it most likely it will clear. It is the second position, turning the head from the dixwell back test 90 degree to the opposite side is the one determining if the otoconia moved in the right way or no. But in the third and the fourth position, it was reported that this is you can expect to have down beating nystagmus, and it was considered by some experts that it's a good indicator. Even when you bring the patient in the sitting position, you could have some few beats of down beating nystagmus. So regarding that, how you interpret, it's always the second position. If it happened to me, I'll just complete. Having down beating nystagmus in the third position is not a bad indicator, and you should complete the treatment. So canal jam also, your interpretation, I regret to disagree, because jam is different and it causes persistent nystagmus. It causes persistent nystagmus. Yes, some patients, because the technique is different from one clinic to another clinic, the waiting time, the size of the otoconia is different. So sometimes every maneuver does not work. And using alternative maneuver is sometimes very wise. It's good. That's why it's good to know some, yani not only one maneuver, you know multiple maneuvers, because for some reason one does not work, so the other can work. These are the comments about your case.
So I have a follow-up question to you, Dr. Alfargal. How
Mhm.
often have you used different maneuvers in treating BPPV? Or do you repeat
Yeah,
the
we
same
use
maneuver again and again?
Yeah, we use more than 30 maneuver in our clinic, and we have some unpublished maneuvers we also use. Actually, it depends how you understand. You have to have a model for what's going on in the inner ear. Where is the otoconia coming from, and where you want to bring. That's why there is now it's become very clear to have the apogeotropic posterior canal BPV. It's now like a routine. Sometimes we see like 3, 4 cases in a week sometimes. So it's possible and it can happen. So for posterior canal, which is the most commonly affected, we use the Ibli maneuver, we use the Simont maneuver, but Simont maneuver also, it has some tricks. Uh, it's not as in YouTube videos. I learned it by the first students of Simont, Alain Terry and Frank. So they have been the first students of Simont himself. They teach me the French, and I brought them to Jeddah to teach how the proper cement to be done. I use some modification for cement, like cement plus, but not frequently. Use the Lee maneuver, which is a modification of the cement by the Korean professor, Professor Lee, because it's more appropriate for those with cervical issue, cervical spine problems. So without any extension of the head. So I use Lee much more than the Cement Plus. I'm not a big fan of the Cement Plus. So we use Ibli, we use Cement, we use the Lee maneuver, and sometimes we use what's called the quick liberatory maneuver, which was published by Luigi Califano. So all the maneuvers, they include moving from the affected side toward the unaffected side. All of them, they have similar concept. So these are the maneuvers we use in our clinic. So whenever you have conversion, like it was jutropic posterior canal typical during the testing or during repositioning converted to apogeotropic, we use also the maneuvers for the apogeotropic. We use frequently the Dicemont maneuver. Having options is very good. And first of all, understanding where is the otoconia and what is the best way to move it back toward the utricle. Okay.
Another question which I often like to ask: how often do these patients have come back and you are forced to revise your diagnosis? So, I'll give you an example. You have a BPPV, you have treated it, he's settled. Does he come back? Have you ever had a follow-up where he comes back and you're forced to think of another diagnosis?
That's a good question. Actually, it's a rule in our clinic. We use it very frequently. So this is a sharp. Sometimes we don't accept less than the nystagmus got cleared before they leave the clinic. So clearance of nystagmus is very good indicator and it's very reassuring. In some conditions, rare conditions, when they have too much nausea, vomiting, they cannot proceed with further testing. That's we see them, and it happened in few of them. They really we reviewed the diagnosis. But the most strong indicator for its BBV or not, if the nystagmus symptoms cleared with repositioning or no. This is the goal. In my teaching, I teach my trainees, that is, we have in our practice, we have gold medals, silver medals, bronze medals. So as in Olympiad, only the gold medals weight much. So that's why I see a question here about suppression, about visual fixation, suppression or something. Always, I teach my trainees that is we like to focus on the gold medals. So if I have a positional nystagmus which was cleared by repositioning maneuver, symptoms and nystagmus cleared, that's really assuring to a great extent that it was PPV. So this is a gold sign. This is a gold medal. So that's why I always highly recommend always to overweight the gold medals. Don't get distracted by bronze medals. Doesn't count much in your order, but always focus in these major things because that's I find them really very helpful. And even if you are newcomer to the field or just started your practice, but always wait more. All the signs and symptoms, they are not the same. You have to categorize them. You have to overweight some of them more than the others because that's what going to drive your uh, clinical decisions in the diagnosis and in the management. But yes, there is strong differential diagnosis in BPV, like vestibular paroxysmia, like CB angle mass, like migrainous positional nystagmus, it is there. It is there, the differential diagnosis, yeah. And all these conditions and even other conditions, carry malformation and others, there is different conditions really which can cause. Most common, like sometimes the migraine really it gives, but it's not hard to differentiate the migraine nystagmus from the BBV nystagmus. Migraine nystagmus, it's always of low amplitude, low frequency and low amplitude. So it's even one look you can recognize from the videos that is this is doesn't go much with PPV. But most of these conditions I always give a trial because when the patient presented to your clinic, the timing of the day, timing after the onset of the symptoms. BPV is always very strong in the first day and in the morning. Then it fades. This is the natural history. It fades over time. Sometimes when they present to your clinic, sometimes they are not in the full presentation. They just have few weak nystagmus, and that should be considered. And yes, we do a close monitor follow-up, and our indicator that is symptoms, nystagmus should be cleared. This is one of the strong indicator to say it was BBV or something else. This is one point. Another point, if you have very frequent BBV, you have to think either there is systemic problem, they have vitamin D deficiency, they have osteoporosis, they have parathyroid, like we have a huge head and neck surgery department. They do a lot of parathyroid surgeries. Most of those patients, even they are young, they have very recurrent due to the calcium metabolism and the vitamin D metabolism got affected in that parathyroid gland dysfunction. They develop very frequent and very severe benign paroxysmal delusional vertigo. So you have to look underlying those with migraine, active migraine. So if you want to decrease the recurrence, those with active Meniere's disease, if you wanted to reduce the recurrence, you have to control the original problem, the original problem. So always, if migraine and PPV, it's important part of the management of PPV is to control the migraine. If it's Meniere's disease with PPV, it's very important to control the Meniere's disease. If it's vertebropasal insufficiency, transient ischemic attacks. And I have seen many cases with during the attacks with posterior circulation transient ischemic attacks, with cerebellar infarction in the acute phase. On top, they have PPV. So actually, why? It's simple, because if you have ischemia to the inner ear, yes, if that ischemia affects the utricle, these parts of the utricle, they get dislodged and go to like one of the canals. So any insult to the inner ear, it can lead to dislodgement of that otoconia, and it can cause the PPV. So we have to not only to look at the PPV, but to look also what could be the predisposing and what could be the primary disease in the ear or in the vestibular system, which causes the PPV to become recurrent or to become resistant in treatment. If you have any other warning signs, intractable headache, you have unilateral deafness, you have facial nerve palsy, you have any other neurological symptoms, you have to be careful, because unfortunately sometimes people, they just any vertigo with head position, they consider PPV, just try to the position. This is big mistake. Patient with unilateral vestibular hypofunction, if you put them in the Dixon bike test, their vertigo become worse. Any vertigo actually can get worse with head positioning, especially in the Dixon bike. Patient with vertebral artery rotation, if you put them in the Dixon bike test, that's easy. They can develop symptoms also. So, uh, the secret of success, in my humble opinion, how really that is, what is more obvious, what is the most strongest sign to follow. Always think about the gold medals, not the bronze medals. If you overweight these gold medals, really, what is very, because I told you sometimes patient has posterior circulation ischemia, but BBV. And when you clear the BBV carefully without too much torsion to the neck or the vertebral arteries, and this is applied to everyone, old in age. You have to be gentle, avoid overextension to the head. That's why I like the Lee maneuver, because much more than the C multiplex maneuver, because there is no extension to the neck, which is the worst movement for the neck. So just fortunately, majority or of cases of PPV, they are posterior canal. Majority of the cases of posterior canal, they have very robust finding. It's very robust, it's classic, typical nystagmus, and majority of them, they respond very well to the repositioning maneuver immediately on a spot. So that's why. So the only case I feel comfort about BBV is when the symptoms nystagmus cleared in absence of any other alerting or alarming symptoms or signs.
So I think we've already taken a lot from your brain. I have one question which
Sure.
I would like you to tell us about is in post-traumatic BPPV, how do you address these patients? Do you treat them just with repositioning maneuvers? Would you like to do something else? How do you address the patients?
That's a very good question, and very early in my career, one neurosurgeon friend, he has a post-concussion case that was 20 years ago. One case with mild head trauma but severe vertigo. And I told, I refer to you because I feel that's, let's say, to see. So it was really the patient has very strong, very severe benign paroxysmal additional vertigo, and I fixed it. Then he started to refer every patient with mild to moderate head trauma because it was a secondary care hospital, private hospital, not a tertiary. So only mild to moderate cases come to him. So every patient with mild head trauma, moderate head trauma, with complaining of dizziness, he referred to me. I can tell you that more than 95% of the cases, they have really BPV. So it's common. So it's common. It's different than the typical benign Parkinson because it can affect more than one canal. So multiple canal, bilateral posterior canal, multiple canal, it's more possible. Depends on the trauma. So I think it's always a little bit more severe. But usually they respond to repositioning. You have to be careful if the neck is injured, if the head is injured. You have always to be gentle, and you have to be careful not to do harm. And I tell you a very interesting case. I have a 16 years old boy presented with fractured temporal bone in one side with complete loss of hearing, complete loss of vestibular functions in that side. And he has PPV on the other side. So he has severe vertigo. He came in the third day. He has a spontaneous nystagmus due to the loss in one side, and he has positive dixol bike on the opposite side. So once I cleared the posterior canal BBV, his symptoms completely cleared. Even he has a complete unilateral vestibular loss, he compensated in couple of 2 3 days. But BBV, the brain cannot compensate well to it. Why? Or get habituated because it strike and disappear, strike and disappear. So the brain cannot know much information about it, cannot deal with it. That's why it's always يعني they got surprised, they got attacked suddenly with the vertigo attacks. That's why its symptoms become much more than if you have a unilateral vestibular hypofunction. So it's also important to if you have because a concussion can cause affect the balance system and vestibular system in different ways, fractured temporal bones, otic capsules fractures, cervical spine injury, whiplash injury. So I think just you have to be careful, proper assessment, but choice of maneuver. Sometimes, yes, in such cases, if there is whiplash trauma to the neck or something, I would like to use a more gentle maneuver like the Lee maneuver to avoid overextension of the head. Multiple canals, more common. mixed canals or bilateral BBV, that it could be common. So a proper assessment and being careful and considering that is the trauma is very variant. You don't know how it's what its exact effect is. So proper and gentle assessment for patient with post-traumatic PPV.
And okay, I'm going to keep picking your brains till you say Masalama. Uh, how often or have you ever resorted to any medical treatment in BPPV?
That's a good question. Yeah, that's a good question. We are not against the medical treatment. Yes, if the patient has too much nausea, vomiting, we couldn't completely clear the condition. Sometimes we give them anti-emetic and vestibular suppressant medication. So that's not an issue, especially if we pick the diagnosis. So some people, especially if they have migraine and they have PPV, they have terrible vomiting and nausea tendency. That's why sometimes you are unable to complete the repositioning, to complete the maneuver, and sometimes unable to complete the exam. And don't get afraid that the signs will disappear. If they have that's too much nausea, vomiting, most likely they have very strong nystagmus. So if you give them antiemetic or something, still you can give diagnosis. There was some publication one about the use of beta histine with PPV. Yes, it can, especially if you have recurrent PPV. And if you have recurrent PPV, if you have PPV secondary to Meniere's disease, I sometimes we prescribe it because it improves the inner ear circulation. And sometimes if you have like some sort of chronic vertebropathy insufficiency or something, the inner ear is the earliest to be affected because it is away from the source of the blood supply. And you know the labyrinthine artery is no collaterals. It has no collaterals. And it run in a bony tunnel. The bony tunnel is full of bony spikes, so it's very vulnerable to ischemia and hypoxia. So sometimes, yes, sometimes if the patient has recurrent, very recurrent, if he has a secondary disease which needs to be controlled, like migraine, like Meniere's disease, like vertebral insufficiency. So yes, sometimes we prescribe the medication. What's wrong is really to not to proper assessment, diagnose which affected canal, do the repositioning maneuver because they are like magic. Most of our repetition have been built by the repositioning maneuvers, successful repositioning maneuver, because really they alleviate the patient issue. But just it's the main line of treatment. Medications is just يعني just some in some cases they are can help, but the main treatment is the repositioning maneuver. And sometimes if the patient condition like he has fractures, yes, it happen. We work in tertiary care hospital, so sometimes you have patients you cannot do, they have unstable cervical spine injury or something, you cannot do repositioning. So in these conditions, it's very justified. So it's just a case by case, but the main treatment should be repositioning, should be to control the risk factors, vitamin D deficiency, osteoporosis, migraine, Meniere, vertebral insufficiency, uh, changing the sleep habits. These are the main line of treatment, but medication is it's justified in some cases. But the mainstream, they just do the repositioning and they get cleared. So it's not a routine to prescribe medication for the cases, and but in some cases it's well justified.
So I think I must stop troubling you after this, but here's a question. In your travels and your interactions with the authorities, because you're widely travel, is there any research being done on the field of BPPV which you think you would like to share with
Yeah, actually, a lot of research يعني being done. First of all, there is biomarkers. There is some biomarkers in the blood plasma to autolin 1. So you have a lab test which can tell you that uh, there is increased possibility. It's not very specific, but tell you there is a high possibility that you have PPV. This is one of the advances in research. Other advances is the imaging. The Japanese people, they succeeded to have a special imaging technique to see the otoconia, especially in the lateral canal, and to see if there is canal jam or no canal jam. But it seems canal jam is more common and of variant presentation than what we think than before. So biomarkers, imaging, there is a lot of research about using the repositioning chairs or guided with some head movement gyroscope or something. And also there is a lot of better understanding. So I mentioned earlier that there is 5 to 6 possibilities where is the otoconia present. Like for example, people think it's always in the canal side. No, otoconia can be in the utricular side, can be in the utricular side, and they can present differently, and they can be resistant to the classical maneuvers. So you have to have some flexibility about how you preciously diagnose. And there is no harm to ask second opinion, to discuss with a colleague. That's very good way. We learn from each other. Discussions very nice, very beneficial for the clinicians. If you face something unusual, just discuss it with more with colleagues. Um, that's important because I remember, I think 20 years ago, I have the first case of multiple canal BPV. And I was really, oh, that's completely different than what's in the textbook, what we have learned in the medical school. But actually, it was very early, and I got some good insight really from one of the American professors. So, if you have something unusual, just discuss it. Think about it, discuss about it. Just don't neglect or don't just interpret lightly or something. No, no, just it's also important to develop your own expertise because your in-depth understanding, your trust in the maneuvers, your trust in the techniques used, it comes from your own expertise. So always still you have your own understanding of the system, your understanding of the disorder, because sometimes what's published is not the absolute fact. Best practice depends on research, yes, but also depends on the clinician expertise. So clinician expertise is very really important. And some people, they see much more atypical conditions than the others. So it happened because we are fortunate in our clinic to have rapid access clinic. So we see the patient in the same day or maximum 1 or 2 days later. That's why we see a lot of typical or unusual cases which people find it very rarely, just simply because we have the rapid access clinic. In some institutes, the patient will come to them 4 or 5 months, 6 months, 7 months after his first experience. So always, and I always encourage you, always see the acutely dizzy patients. You will become a master. Because all the science, all the interesting science will be during the acute stage. So always some misconceptions, like if the patient has medication, don't forget about this is nonsense. Some of those who write the books, they never practice. And there is very famous story about the Encyclopedia of Galen. He published the greatest textbook which is survived for 1,000 years. And he mentions that is always vertigo occurs due to cerebral congestion. And he proposed that the treatment should by removing blood from the patient. And this misconception survived 1,000 years. And when Menieres discovered the relation between the inner ear and vertigo, he was very shy, very shameful. It took him many trials, and he cannot, frankly, to say the vertigo comes from the inner ear because that misconception survived 1,000 years. So there is no holy books when it comes to vestibular science or knowledge or practice. And always develop your own insight by watching cases, follow up your patients, learn from your patient. We call when every time we fail in something, we call it learning experience. So just be happy with those learning experience because that's what really teach you very well. When you fail, when you cannot do, you don't know, when you cannot the proper diagnosis, when you cannot get the expected outcome, just think more, read more, ask more, communicate more, discuss more. Then you start learning really, you're learning with a solid, clear knowledge that comes from that situations. And we never clear a patient without full explanation for the whole scenario. And sometimes we follow the patient 4 or 5 times just to know what is the end of the story. So like a patient has viral vestibular neuritis. So initially it was superior, then after a few days it becomes a whole nerve. Then he developed the BBV, secondary BBV. We treated the BBV, then some conversion of the BBV, then we treated again. So this kind of follow up with insight. Don't use predetermined template. No, don't use the predetermined template. Be open that you will see signs which you cannot understand. You see things, scenarios which does not fit with your original knowledge. That's common. And when you fail, always think more, spend more time, ask, discuss, because that learning experience, which really gives you the insight, wisdom, and also the confidence.
I must thank you most profoundly. I think you have been a professor and you have taught exactly like a professor should. So I'm deeply obliged to you. I did not open it out to questions. I was unsure whether
No, if you
I
want to
could.
answer, I am okay. No
I'm
problem for me.
yeah. So I'm.
If you
I'll open
need,
it out. If anybody wants to ask a question, simply raise your hand and
To
start.
add,
no,
sir,
I am fine. If someone wants to ask, I'll be happy to answer.
Sure. So the floor is open now for people to ask questions. You should
Sure,
please go ahead
sure.
and ask either
Pleasure.
um, through the chat or directly.
One
Directly
question
better.
from hello, good evening, Professor. Uh,
Go on.
I'm Dr.
Good
Pratishtha from
evening.
Lucknow. Sir, I just want to know how the sit-up vertigo present and how will treat well.
What is?
The sitting up vertigo that is
Yeah,
in short
sitting up
arm. Yeah.
vertigo.
Yes.
Yeah, that's a good question actually. So this is the SOCO variant or sitting up vertigo or abiotropic posterior canal, all the same. And as I mentioned, that is like you have to understand the Ewell's law. If you don't master the Ewell's law, you will never be a master in vestibulogy. So that's very important. So suppose one patient you put in the right dixwall bike, he has down beating torsional nystagmus, down beating torsional nystagmus and torsional towards the left side. Then when you bring that patient to the sitting position, he has up beating with torsion towards the right. So actually, this is example of the abiotropic posterior canal, abiotropic posterior canal, where the otoconia, it's not in the typical position, but it's in the other way. So that's why when you put the patient in the Dixwell bike test, there will be ambulopetal endolymphatic flow, which causes inhibition. When you bring the patient in the city, there will be excitatory ambulofugal. That's why you have the upbeating nystagmus and you have stronger nystagmus. Another scenario, if the otoconia in the utricular side, if the otoconia in the utricular side, Yes, if the otoconia and the utricular side, sometimes they show better. I saw in the chat someone asking about the half dixel bike. So yes, instead of putting the head 30-degree extension downward, we put it like in the caloric position, 30-degree upward. That's called half dixel bike, and it better shows the nystagmus if there is cubulolysis or if there is canal utricular side cubulolysis. So in utricular side also that can explain this kind of setting up vertigo. So actually, in the literature is still some because like in our clinic now we started to have like more cases because maybe we get to know about it. So abiotropic posterior canal is really is existing and it's not rare. It's not uncommon. It is there, and it can happen during the testing. It can happen during after the repositioning, and it can be the initial presentation. So we recognize and we treat. And it's always that's why I mentioned use the gold medals. So the solid physiological background here is the eye movement and its correlation to the semicircular canals. That's what give you can guide you where is the otoconia and most likely by provoking. And don't depend on one test because like as mentioned in the chat we do right dixel bike left dixel bike we do bow and lean we do the McClure Bagnini we do the half dixel bike test uh, we do head extension so sometimes we need really to get more information to better understand the condition. And I'll give you one secret, very precious secret. You know, if you think how the autoconia could lead to BBV, they need to precipitate and they need to gather together to make a mass able to trigger the symptoms and signs. So one of the leading questions, ask your patient, how is his sleeping habit? So if someone persistently and constantly sleeping on his right side, so don't expect that BBV is always from the right side. Doesn't make sense to be developed in the left side, except if there is very special scenario, but most likely it will be in the right side. That's why worldwide BBV is more common in the right side than the left side, because majority of the people they lie on their right side. So using one still overlap about the possibilities or the explanations. So covariant, setting up vertigo, apogeotropic posterior canal, utricular side, copiolysis, all these kind of things still the same name. How we treat, we love too much the Dicemont maneuver. So Dicemont maneuver, quick liberatory maneuver are our favorite for these cases. And yes, sometimes if you just repeat the Dixol bike many times, that can happen. By the way, this is sometimes in some cases we use the habituation exercise. Sometimes BBV is resistant. Small otoconia, you cannot control them by guiding them with the gravity because they don't have much mass and the patient is symptomatic. We use habituation exercises, but since many years we don't use the branded Daruf. We use like home cement. Sometimes we use repeated head extension and sitting head extension and sitting because habituation is based on physiological background, very strong physiological background. If I clap my hand beside your ears, you will jump. Second time, you will just blink. After a few times, no response at all. So habituation is physiological. So sometimes in resistant cases, we ask them to repeat the triggering movement or triggering position, triggering movement many times a day. So that's why habituation can happen. I hope I answered your question.
Yes, yeah.
Yes, sir. Yes, sir.
Can I
Thank you, sir. Thank you, sir.
Mr. Bart, Dr. Bart
Mhm.
Zornwell wanted to ask a question. Go ahead.
Sure, Bart is my good friend. Yeah.
Hello, Dr. Mohammed. Thank you for
How are
your
you,
great
brother?
excessive explanations. I have a question regarding the migraine as a risk factor for BPPV.
Yes.
Uh, I cannot understand the physiological explanation behind that. I'm more
Okay.
doubtful about is there possible a central positional vertigo that has been misdiagnosed as BPPV? What are your opinions regarding that?
Good. That's very good question. But tell you, I started my career as neurologist, and that was on 1998. And I was big fan of neurology. During that time, I got a book about migraine. I wish I can get it back, because that book really it gave me a lifelong a life lasting insight. So the explanation of migraine from that book was that is the stress lead to platelet aggregation, and the platelet aggregation will start to release serotonin, which trigger like vasoconstriction and trigger the attacks. So actually, vasoconstriction was very clear, vasospasm, not constriction, was very clear pathophysiological mechanism. Maybe it was the earliest and the strongest during that time. So vasospasm is common, and there is very strong connection between migraine and the trigeminal nucleus. And that trigeminal parasympathetic and sympathetic fibers is responsible for the vasa nervosa of the labyrinthine artery. So it's actually determine if the artery got spasm or good dilatation. And that's why it's common for migrainer to have blurry vision, black spots, flashes of light, this dimness of vision. That's in the vasospasm stage. Then afterwards, they got the vasodilatation, reactive vasodilatation, which was very severe throbbing headache. So vascular or vasospasm was one of the main mechanisms attributed to migraine, or explained how the migraine can cause its symptoms and its effects. And I believe, yeah, it can happen. And that's why there is also, from our experience, hearing loss, sudden sensory neural hearing loss is more common is more common in migraineurs than the general population. So this kind of vasospasm, and there is evidence, strong evidence for physiological connection between the trigeminal nucleus, trigeminal parasympathetic and sympathetic fibers, which are responsible for the vasa nervosa of the labyrinthine artery. So how the labyrinthine artery is constricted, if it is dilated, constricted, that's yeah, there is evidence for it in the literature. So yes, yeah, you have to differentiate if it's BBV or migraine, but it's clear also in the literature, clear in our experience, that's it's BBV is much more common in migraineurs than the general population, at least three folds. And when you do repositioning, that component will be completely cleared. But always, if this you didn't treat the migraine, still it will be little bit recurrent. Thank you, Bart.
Right. Thank you.
So I think we have really taken you far beyond what we should have. I apologize for that, but I'm very grateful to you on behalf of
No, it's a
all of us.
pleasure, and we are
Uh,
very, very happy, really.
so one more question.
Sure.
As a professor, I just want to know, I'm just collecting the data. Is
Mm.
there any association of vestibular migraine between B12 deficiency and vitamin D? What I'm finding in my patients, it's a lower limit of B12, like 211 to 900 range, and vitamin D range is 30 to 100. That is normal. But where we are getting the 40 in vitamin D and 200 around in vitamin B12, we have found that is lower limit. After giving it in proper injectable and the course what we are following, the patient get suddenly relieved. Is it the lower limit is not up to the mark? We have to extend the lower limit from 200 to 400 of
That's
B12
very
and
good. Very good question. I hope I get it right. For the vitamin D, for example, the normal level was when we started was 30 nanogram per deciliter. Now, what we consider normal for our patient above 50. And in patients with BBV, I target them to go for 60 and 70. So this is was for the vitamin D. And now if the vitamin D is less than 50, we really give them supplements. And that make big change. And I witnessed that evolution from using 30 to 50 as a lower cutoff of normal. And always I like to keep the level above that cutoff, give it in the safe range. Don't exceed the toxic range, but keep it in higher, little bit higher in the average range, but not to the lower limit. The relation between migraine and vitamin B, yeah, now I personally prescribe the vitamin B2, riboflavin for to as a prophylactic of migraine. So and with the coenzyme 10 with the magnesium, yeah, I think it's a good cocktail, and many of the patients, considerable percentage of the patients, they got better in it alone or with other medications. So the relation between migraine and these trace elements or vitamins, yeah, there is some relation because uh, migraine results from some sort of disturbance of the homeostatic balance in the neural system. So sometimes it's that's why ionic disturbances, vitamin deficiencies, hypoglycemia, uh, this thing is it has some sort of relation. So some the relation can be direct relation or can be indirect relation. For example, it's known that is hunger, it can trigger the migraine. So if the patient has malnutrition, hunger, repeated or something, he could have migraine. He could have hypovitaminosis. Migraine is common in anxious patients. They always have GIT upset, gastric upset, and the gastric problems. Sometimes malabsorption can happen. They have also irritable bowel syndrome with malabsorption. So hypovitaminosis can occur. So it just whenever you do something, you observe. It just always to know to change it into a fact or to be a recommendation for the mainstream practice. It need more evidence. It need more studies, replicated studies. It need more large number of subjects in the study, and it need to have like some sort of clear mechanism about the correlation. But personally, yes, I have no issue about this one. On the contrary, there is no harm to give vitamin B12 if they have borderline because it's also improves the general well-being. So improving the general well-being will reflect to many aspects of, especially of dissipation. And that's bring us to an important point really, which is the well-being of the patient. We don't treat the ear, we treat a human being. So always your target, whatever your specialty or your background in the healthcare system, it's very important to put in front of your eyes that your target is well-being of the patient. So that's important to improve sleep, to improve nutrition, to improve يعني life management, stress management. It's very important to treat as a human being rather than inner ear or an ear.
Thank you so much, Professor. Thank you. Professor, I had just discussed this, okay, how much we have to give between B12 and D at the higher side, because we have to decide some limit. When we are giving the injectable, the patient blood reflect 2000 around level 2000 above. Should we continue it because it sometime it reflect the kidney diseases also? Some nephrologist
So
told
it's
us like,
always all the vitamins they have also toxicity range. So that's why we don't like to overdose. I see a lot of patients when I review their lab test results, I find that really their levels exceeded, especially vitamin B12, because patients think this is very good to keep on taking. So sometimes even after the prescription, they keep on taking, thinking this is good for them. So everything it has over is bad, under is bad. So always the exact or the precise. That is the best, the middle, the average. So always it's better. Yani for me, it's like 2 weeks for something. That's always more than enough. But I don't recommend to any vitamin, even magnesium and vitamin E, I use it only for 1 month. So it's always be careful because all these vitamins they have also a toxicity range, and they can be toxic. And no need to go just a little bit above the cutoff level. Then on periods, like after a few months, you can repeat again for a couple of weeks, but always avoid this kind of excessive supplements because, for example, just one example, excessive vitamin A, it can need to increase the intracranial tension. So actually, it can cause vitamins can uncontrolled, unwise use of vitamins or minerals. It can really affect many organs in the body and can have deleterious or negative effects. So just being wise, always moderate and wise. Don't get very, very enthusiastic for any treatment modality or something. What we learned from that practice journey is to be gentle in everything, in your diagnosis, treatment, management, to be gentle. So that's what, if in one word you want my 25 years of experience, just being gentle in everything.
Thank you so much, Professor, for sharing your precious experiences. Thank you.
Thank you, Dr. Alfargal. We are very grateful to you.
Thank you, my friend. Thank you, Anusha, for the presentations. Thanks for the audience for the very interesting questions. All
Thank
the
you.
best for everyone.
Ramadan Kareem also to you. Thank you.
Thank you.
Thank you so much, sir.
Well,
Thank you, Doctor. Great Ramadan.
thank you, everyone.